One in six couples will struggle to conceive, and most never find out why. The answer isn't always in a clinic. It could be hiding in your daily routine, your environment, or your stress levels. What doctors don't always tell you about infertility might genuinely shock you. Keep watching. Let's start by getting clear on what infertility actually means, because the word itself carries so much emotional weight that it often gets misunderstood. Clinically speaking, infertility is defined as the inability to conceive after 12 months of regular, unprotected intercourse for couples where the woman is under 35. For women over 35, that window shortens to 6 months before investigation is recommended. This distinction matters because age genuinely affects the urgency of evaluation, and waiting a full year when you are 38 is not the same as waiting a year when you are 28. There is also something called secondary infertility, which is when a couple has successfully conceived before but struggles to do so again. This form is surprisingly common and often dismissed, with people being told they should simply be grateful for the child they already have. That response, while perhaps well-intentioned, is medically unhelpful and emotionally dismissive. Struggling to conceive a second or third child is a legitimate medical concern that deserves the same attention as primary infertility. Now here is a statistic that stops most people in their tracks. According to the World Health Organization's 2023 report, 1 in 6 people of reproductive age are affected by infertility globally. In the United States, roughly 10 to 15% of couples face this challenge. In the United Kingdom, the NHS estimates it affects 1 in 7 couples. Australia and Canada report comparable figures, and across Europe, fertility rates have been declining steadily for decades. These are not small numbers. This is a global health issue that touches families across every culture, income level, and age group. And yet it remains one of the most underdiscussed topics in mainstream healthcare. Before we go any further, we need to bust one of the most damaging myths in reproductive health. Infertility is not mostly a female problem. This belief is deeply embedded in how society talks about conception, and it causes real harm because it delays diagnosis and puts unfair emotional pressure on women. The truth is that male factor infertility accounts for approximately 40 to 50% of all infertility cases. In another 20 to 30% of cases, both partners have contributing factors. This means that in the majority of infertility situations, the male partner plays a significant or partial role. Yet in many cultures and even in some clinical settings, the woman is investigated first, most thoroughly, and most repeatedly, while the man's fertility is assumed to be fine. That assumption costs couples time, money, and enormous emotional suffering. So let's talk about male infertility with the seriousness it deserves. Sperm health is evaluated across 4 key parameters: count, which is how many sperm are present; motility, which is how well they move; morphology, which is the shape and structure of the sperm; and volume, which refers to the amount of semen produced. A semen analysis is one of the least invasive and least expensive fertility tests available, and yet it is frequently one of the last things ordered. What most people do not realize is that sperm takes approximately 74 days to fully develop. This means that whatever a man was exposed to, eating, drinking, or experiencing 3 months ago is reflected in his sperm today. Lifestyle changes take time to show results, but they absolutely do make a difference. The most common correctable cause of male infertility is something called a varicocele, which is essentially a varicose vein in the scrotum that raises the temperature around the testicles and impairs sperm production. It is found in about 15% of all men and in up to 40% of men being evaluated for infertility. The good news is that it is treatable. Hormonal imbalances are another significant factor. Low testosterone, elevated estrogen, and thyroid dysfunction can all interfere with sperm production in ways that are often completely silent, meaning a man feels perfectly healthy while his fertility is being quietly compromised. Genetic causes also play a role. Conditions like Y chromosome microdeletions or Klinefelter syndrome affect sperm production at a chromosomal level and can only be identified through specific genetic testing that is not part of a standard semen analysis. One of the most underreported contributors to male infertility right now is the misuse of testosterone supplements and anabolic steroids. Many men take these substances for bodybuilding or to combat fatigue, not realizing that external testosterone signals the brain to shut down the body's own hormone production, which essentially switches off sperm production entirely. This effect can persist for months or even years after stopping use, and some men experience permanent damage. If you or someone you know is using testosterone therapy and planning to have children, this is a critical conversation to have with a urologist or reproductive endocrinologist immediately. Lifestyle factors matter enormously for sperm health. Smoking has been shown in multiple studies, including research published in the British Medical Journal, to reduce sperm count and motility by up to 22%. Chronic alcohol consumption disrupts testosterone production and damages sperm DNA. Obesity is linked to hormonal imbalances that directly impair sperm quality. Heat exposure is another frequently overlooked issue. The testicles are located outside the body for a biological reason. Sperm production requires a temperature slightly below core body temperature. Regularly using laptops directly on the lap, sitting in hot tubs frequently, or wearing very tight underwear may seem like minor habits, but over time they create a thermal environment that suppresses healthy sperm development. Environmental toxins represent a growing and genuinely alarming area of research. Endocrine-disrupting chemicals, found in plastics containing BPA, in pesticides, in certain personal care products, and in industrial compounds called phthalates, mimic or interfere with hormones in the body. Studies have shown measurable declines in average sperm counts across Western populations over the past 50 years, and researchers increasingly point to environmental chemical exposure as a key contributing factor. This is not a fringe theory. It is mainstream reproductive science that has prompted policy discussions in the European Union, the United States, and Australia. Now let's turn to female factor infertility, which is equally complex and deserves the same depth of understanding. The most common cause of female infertility is an ovulation disorder, and the most common ovulation disorder is polycystic ovary syndrome, widely known as PCOS. PCOS affects approximately 1 in 10 women of reproductive age, making it one of the most prevalent hormonal conditions in the world. It is characterized by irregular or absent ovulation, elevated androgen levels, and often the presence of multiple small follicles on the ovaries. Many women with PCOS also have insulin resistance, which compounds the hormonal disruption. The frustrating reality is that PCOS presents very differently from woman to woman. Some women have textbook symptoms like irregular periods and excess hair growth. Others have regular cycles and no obvious symptoms at all, and only discover the diagnosis when they struggle to conceive. Another ovulation disorder worth understanding is hypothalamic amenorrhea, which is the loss of menstruation due to signals from the brain being suppressed. This is commonly triggered by extreme exercise, very low body weight, or chronic psychological stress. The brain essentially interprets these conditions as a signal that the environment is not safe for reproduction and turns off the hormonal cascade that drives ovulation. This is particularly relevant for athletes, dancers, and women who have been through periods of significant weight loss or prolonged high stress. The body is not malfunctioning in these cases, it is actually responding exactly as it was designed to, but the result is infertility until the underlying triggers are addressed. Structural causes of female infertility are also critically important and frequently silent. Fallopian tube blockage is one of the most common, and it is often caused by a past infection that was either undetected or untreated. Chlamydia is perhaps the most significant culprit here. It is the most commonly reported sexually transmitted infection in the United States, the United Kingdom, Australia, and Canada, and the majority of people who carry it have absolutely no symptoms. Left untreated, chlamydia causes pelvic inflammatory disease, which creates scar tissue in the fallopian tubes that can permanently block the path between the ovary and the uterus. This is why sexual health screening is not just about personal health, it is directly connected to future fertility, and routine STI testing should be normalized for all sexually active adults. Endometriosis is another condition that deserves far more public awareness than it currently receives. It affects an estimated 1 in 10 women, yet it takes an average of 7 to 10 years from the onset of symptoms to receive a diagnosis in the United States and the United Kingdom. Endometriosis occurs when tissue similar to the uterine lining grows outside the uterus, often on the ovaries, fallopian tubes, and surrounding pelvic structures. It causes inflammation, adhesions, and scarring that can impair egg release, block the tubes, and create a hostile environment for fertilization and implantation. Many women with endometriosis are told for years that their painful periods are normal, that they are being oversensitive, or that things will improve with hormonal contraception. While hormonal treatment manages symptoms, it does not treat the underlying disease and it does not protect future fertility. If you have been experiencing severe menstrual pain, pain during intercourse, or chronic pelvic pain, please advocate for a thorough gynecological evaluation. You deserve to be taken seriously. The role of age in female fertility is a topic that is often discussed either with unnecessary alarm or not discussed honestly enough. The truth sits somewhere in the middle. A woman's egg supply is set before she is even born. She does not produce new eggs after birth, unlike men who continuously produce new sperm. From puberty onward, eggs are lost every month and the quality of remaining eggs declines with age. The most significant decline in fertility begins around age 37, and this is not a social construct or a media exaggeration. It is biological reality driven by the increasing rate of chromosomal abnormalities in aging eggs. However, and this is important, many women conceive naturally and have healthy pregnancies in their late 30s and early 40s. Age reduces the probability of conception but does not eliminate it. What matters is having an honest, individualized conversation with a reproductive specialist rather than either panicking or dismissing the biological timeline entirely. Thyroid health is one of the most overlooked contributors to both male and female infertility, and it deserves a moment of specific attention. The thyroid gland regulates metabolism, but it also plays a direct role in reproductive hormone balance. Even subclinical hypothyroidism, where thyroid hormone levels are only mildly low and a person feels largely normal, has been associated with irregular ovulation, implantation failure, and increased risk of early miscarriage. Elevated prolactin levels, a condition called hyperprolactinemia, can also suppress ovulation entirely by interfering with the hormones that trigger egg release. Both of these conditions are diagnosable with a simple blood test and are highly treatable, yet they are not always included in a standard fertility workup unless specifically requested. Beyond the medical and biological factors, we cannot have an honest conversation about infertility without acknowledging the profound role that stress plays. The relationship between psychological stress and fertility is complex and bidirectional. Chronic stress activates the body's cortisol and adrenaline systems, which can suppress reproductive hormones in both men and women. Research has shown that women with higher levels of a stress biomarker called alpha amylase take longer to conceive. At the same time, the process of trying to conceive is itself deeply stressful, creating a cycle that can be genuinely difficult to interrupt. This does not mean that infertility is caused by not relaxing enough, which is one of the most frustrating and unhelpful things people say to struggling couples. It means that stress management is a legitimate part of a comprehensive fertility strategy, not a replacement for medical care. So, what can couples actually do with all of this information? The most important first step is to seek evaluation together and early. Both partners should be assessed simultaneously rather than sequentially. A basic fertility workup for a woman typically includes blood tests to assess hormone levels including FSH, LH, AMH, and thyroid function, as well as a pelvic ultrasound to evaluate the uterus and ovaries. For men, a semen analysis is the essential starting point. These investigations are not frightening, they are empowering, because knowledge is the foundation of every effective plan. From a lifestyle perspective, the evidence supports several practical steps for both partners. Maintaining a healthy body weight significantly improves hormonal balance and ovulation regularity. Regular moderate exercise is beneficial, but excessive high-intensity training can suppress reproductive hormones. A Mediterranean-style diet rich in vegetables, whole grains, healthy fats, and lean protein has been associated with better fertility outcomes in multiple studies. Folic acid supplementation is recommended for women trying to conceive, and some evidence supports the benefit of antioxidant supplements like coenzyme Q10 for both egg and sperm quality. Reducing alcohol, eliminating smoking, minimizing plastic food container use, and choosing organic produce where possible are all reasonable steps given what we know about environmental toxin exposure. Most importantly, if you have been trying to conceive for the recommended time period without success, please do not wait and wonder. Early evaluation and intervention dramatically improve outcomes across almost every category of infertility. The field of reproductive medicine has advanced extraordinarily in recent decades. Conditions that once meant permanent infertility are now treatable. Couples who once had no options now have several. The conversation you have with a reproductive specialist today could change the entire trajectory of your family's story. You are not alone in this. The science is on your side, and understanding why something is happening is always the first and most powerful step toward changing it.